Assalamu alaikum, friends. It's me, Dr. Mohammed Kazafi, and I am trying to present one very important case which is called the tethered cord syndrome. And tethered cord syndrome, and you are watching Dr. Mohammed Kazafi Views. So, here we start. You can see this is the tethered cord syndrome, and here you can appreciate it. What are the causes of the tethered cord syndrome, why tethered cord syndrome is happening, and what is the tethering of cord actually. I want to try to explain you here. So let's start. So as I mentioned before, there is, you can appreciate in this picture, it is showing the tethering of the cord, and associated with the definitely there is a conus medullaris you can appreciate here. So the tethered cord syndrome is a stretch-induced clinical constellation arising from tension on the spinal cord due to anchoring to the elastic, or we can say inelastic structure, and the tethered cord syndrome may present with the neurological, urological, musculoskeletal, dermatological, and gastrointestinal abnormality, and which may be congenital or acquired in etiology, and long-term outcome are favorable with appropriate diagnosis and treatment. And this activity reviews the pathophysiology, clinical presentation, evaluation, and treatment of the tethered cord syndrome, and highlight the role of the interprofessional team in evaluating and treating this condition. So that's why I try to present this picture in front of you, and you can see there is a how the normal spinal cord is behaving, and then how the leptomeningeal and a seal, you can see the spinal cord is attached to the fatty growth, and in the third part, in the third type, which is you can see attached to the scar tissue, and the spinal cord attached to the scar tissue here. So I want to tell you further regarding that tethered cord syndrome. So you know that there is a tethered cord syndrome is a well organized, or we can say well recognized, and a cause of deterioration in patient with the myelomeningocele with an estimated. So I wanted to mention here the tethered cord is a well recognized cause of deterioration in patient with myelomeningocele with an estimated 1/3 of the patient requiring spinal cord untethering in childhood, and the tethered cord syndrome is defining as a stretch-induced clinical constellation arising from tension on the spinal cord due to caudal anchoring to the elastic structure. An inelastic structure restart vertical movement of the spinal cord and may arise from congenital etiology such as the myelomeningocele or acquired etiology such as scar formation. So stretch-induced functional changes to the spinal cord function may result in neurological, urological, musculoskeletal, or gastrointestinal abnormalities, and the term tethered cord syndrome originates from an article in 1976 authored by the Hoffman et al., wherein they describe the 31 patients with elongated spinal cord whose symptoms improved following sectioning of the filum terminale. So sectioning of the filum terminale, when we are listening, it seems to be very dangerous, but it is at that time it's happened. So acquired etiology for the tethered cord syndrome include spinal cord tumor and scar formation. So as you know, the epidemiology, the rate of the myelomeningocele in the United States is about 0.3 to 1.43 per 1,000 births, and with regional difference, the incidence of the myelomeningocele has declined because of the folate supplementation and improved maternal nutrition in addition to the other factor. It is estimated that the 1/3 of the myelomeningocele patient will require tethered spinal cord release in childhood, with the incidence of the symptomatic spinal cord tethering increasing during period of the rapid growth. So, regarding the pathophysiology, you know that the excessive traction on the spinal cord due to the tethered cord syndrome in impaired spinal cord perfusion and the oxidative metabolism, reduced glucose metabolism, and the mitochondrial failure with corresponding Actually, the clinical presentation of the tethered cord syndrome is broad and varies with underlying etiology and the age at presentation. Children and toddler commonly present with the sensory motor dysfunction, with the sensory loss occurring in the non-segmental distribution. Pain in the back and the lower extremities also present. Complain within this age group. So for patient in the late childhood and the early teenage, or we say the teenage year, pain is the predominant presenting symptom, and specifically non-dermatomal pain in the lumbosacral region, perineum, and the lower extremities. So the incontinence and the sphincter dysfunction are also common symptom in this age group. So in the adult patient with the history of the spina bifida, the clinical presentation is like that: the adolescent predominantly with pain and sphincter dysfunction, which can be provoked by flexion and extension movement of the lumbosacral spine for the adult patient without a history of the spina bifida. The pain remains the predominant presenting symptom, followed by weakness and the urological dysfunction. Trauma often lead to the symptomatology within the population and may involve major direct trauma to the spine, or may be mild from provoking factors such as the exercise, pregnancy, childhood. It is hypothesized that this subset of the patient, the degree of the tethering is not the significant enough alone to cause symptom. And in that regard, this is the hypothesis that the subset of the patient, the degree of tethering is not the significant enough alone to cause the symptom, but added trauma increase the stress on the already tense spinal cord, ultimately leading to the neurological or urological deterioration. Because of that, patient of all ages may be present with the urinary sphincter dysfunction, which may present as the urinary tract infection without an alternative cause, and or episode of the incontinence between the scheduled straight catheterization. Bowel dysfunction may also occur, and the patient can experience constipation. So the physical examination play a key role in the diagnosis of the tethered cord syndrome, and it begins with the examination of the dorsal spine for cutaneous manifestation of spina bifida, as well as the presence of the scoliotic deformity, and the cutaneous stigmata may be the only evidence of the tethering lesion in the neonate and infant, and may include their tuft dermal sinus or hemangioma or lipoma. Here I want to show you. Yes, so tethered cord syndrome, as you know, that the patient of all ages may present with the urinary sphincter dysfunction, which may present as the urinary tract infection without an alternative cause, or the episode of the incontinence between the scheduled straight catheterization. Bowel dysfunction may also occur, and the patient can experience, the constipation. And the physical examination play a key role in the diagnosis of the tethered cord syndrome, and it begins with an examination of the dorsal spine for cutaneous manifestation of the spina bifida, as well as the presence of the scoliotic deformity and the cutaneous stigmata, may be the only evidence of the tethered lesion in the neonate and infant, and may include hair tuft and the dermal sinus or the hemangioma and the lipoma. So the lower extremities should be examined for the orthopedic deformities which are commonly associated with tethered cord syndrome and may include the, we can say, the pes cavus or we can say the equinovarus deformity, and this equinovarus deformity and the hip subluxation and the sphincter distribution may be difficult to discern in the young patient less than 1 year of age. But as you know, but anorectal malformation in addition to the lower extremity deformity should raise the suspicion for the tethered cord syndrome. The remainder of the physical examination includes through motor, sensory, and the deep tendon reflex, and the gait assessment, and the deep tendon reflex and the muscle tone can be variable. So the gait assessment is the important and may affect by the spasticity and the orthopedic deformity, such as the foot deformity or the scoliosis. So I want to tell you here what we can do for the evaluation, and I want to present here what we are doing for the evaluation. Definitely evaluation, and start with the history and the physical exam, and I already explained to you about the history and the physical exam. See how you can see this skin deformity, you can see from the skin, and you can palpate here. And you can check and you can find there some tuft of the hair here. As you know, the tethered cord syndrome could be the congenital, or we can say there is a congenital anomaly. So it can develop embryologically. How you can appreciate there, what is the neural plate, you can appreciate here. Then you can remember the neural groove, and here you can see the neural folds, and in between the neural folds, and you can say the under the neural groove you can notice the notochord, and here you can appreciate how the neural grooves are improved and getting deep more and simultaneously crest of the neural crest are or we can say the crest of the neural fold has been matured, and the neural fold you can appreciate here, and this notochord you can appreciate, and then the crest of the neural fold turned, and the neural crest cells actually migrated laterally, and you can appreciate here how the skin form and the neural crest cell form and the neural tube can develop and the notochord behind it. So this is the normal embryology happen, but if anything happen abnormally, definitely it may cause the tethered cord syndrome, and that's why we are talking about it. So in tethered cord syndrome is suspected based on the clinical presentation and magnetic resonance imaging of the spine is the radiographic modality of choice, and MRI aids in the demonstrating the level of the conus medullaris, identifying lesion associated with the tethered cord syndrome and surgical planning. Despite the variability, the normal level of conus is at or above the second lumbar level, and the thickness of the filum terminale can also be evaluated. A thickness greater than 2 mm can be considered abnormal in children, although this is the somewhat controversial. Having the patient or the reposition for the prone in addition to the supine, the MRI to demonstrate evidence of the motion of the spinal cord also has been described with the lack of the motion between the supine and the prone position. MRI scanning suggesting a tethered cord spinal cord, and the MRI can further and visualize underlying of the pathology associated with the spinal cord tethering, including myelomeningocele or the lipomyelomeningocele, and the split cord malformation tumor, such as the constructive interface with the steady state, and the MRI sequence may be used in determining the case, as it has been shown have superior sensitivity to the T2 weighted MRI sequence, in addition to the MRI, standing scoliosis, X-rays, and the computerized tomography, CT scan, and can also be considered to further evaluate scoliosis of the patient. In shunted hydrocephalus, the evaluation of the tethered cord syndrome should begin with an assessment of the shunt function, as the shunt function or the shunt malfunction can have a similar presentation. A malfunctioning shunt should be revised and the patient should be reserved several weeks post-operatively if there is a clinical improvement and following shunt revision. Then tethered cord should be strongly considered. So the urodynamic testing play an important role in establishing the sphincter dysfunction relevant parameter in the evaluation or evaluating the neurogenic bladder include the bladder compliance and the total bladder capacity and the pressure, inhibition, contraction, leak point pressure, sensation, and the electromyography activity. So the urodynamic testing play an important role in establishing the sphincter dysfunction relevant parameter in evaluating the neurogenic bladder include the bladder compliance, total bladder capacity, and the pressure inhibited, contraction, leak point pressure, sensation, and electromyogram activity. Detrusor hyperreflexia is the most common finding, but we can say the dyssynergia, decreased bladder compliance, and the decreased sensation can also occur. So the formal urodynamic testing may also be useful for serving as a marker to document stability or the improvement of the function following in untethering surgery. So surgical management is also important, and the surgical intervention is indicated for the tethered cord syndrome if clinical signs and symptoms are present in conjunction with the radiographic finding, and the surgical step for the spinal cord untethering being with midline skin incision corresponding to the level of the conus at the filum terminale junction, and the paraspinal muscles are subsequently separated from the spinous processes and the laminated, or we can say the lamina medial to the articular facet of one or two level. Then the laminectomy or the laminoplasty may be performed with attention to avoid violating the facet joint laterally. So once the dura is exposed, a midline incision of the dura and the arachnoid membrane is made. And I want to show you here one thing. So here you can appreciate there is definitely the dimpling of the skin because of it is definitely a sign of a tethered cord syndrome. And then you can appreciate the MRI and the MRI sagittal views and showing you how the tethering is happening. And here once I want to tell you, once the dura is exposed, so midline incision of the dura and the arachnoid membrane made and stitches are placed at the dural edges. So the gentle caudal dissection of the conus medullaris proceed until the exit of the most caudal, we can say the coccygeal nerve root is identified with the filum terminale and beginning caudally to the most caudal, we can say the coccygeal nerve root. And once the filum terminale is identified, any adherent coccygeal or lower sacral nerve are dissected from the filum terminale, and once clinically dissected, the filum terminale is cauterized and resected approximately 5 mm above conus filum junction. And if there is a question as to whether the filum terminale is completely freed of the adherent nerve root or the nerve root, stimulation studies can be employed intraoperatively. So it is very, very important to understand once the filum terminale is identified, any adherent coccygeal or lower sacral nerve are dissected from the filum terminale, and once cleanly dissected, then filum terminale is cauterized and resected approximately 5 millimeter below the conus filum junction. And if there is a question as to whether the filum terminale is completely freed of the adherent nerve root or the nerve root stimulation studies can be employed intraoperatively. So it is very important to understand, and following untethering and the reception, or we can say the inspection of the nerve root and the dura is closed in the watertight fashion, and which can be confirmed by asking anesthesia to provide it Valsalva maneuver, and then the sealant can be applied over the dural closure. And here, following untethering and the inspection of the nerve root, the dura is closed in a watertight fashion, which can be confirmed by asking anesthesia to provide a Valsalva maneuver, and sealant can be applied over the dural closure, including synthetic sealant and dural substitute as a combination of the two. And if the laminoplasty is performed rather than, we can say, a laminectomy, absorbable, or we can say the titanium plate can be used to fix the lamina back into the place, and once hemostasis have been achieved, then the incision can be closed in a multi-layer closure. And intraoperative electrophysiology, definitely electrophysiological monitoring can be considered, as it has been found to reduce the perioperative or the perioperative surgical risk. Here, so as you know, the following untethering and the inspection of the nerve root, the dura is closed to the watertight fashion, and which can be confirmed by asking the anesthesia to provide a Valsalva maneuver, and the sealant can be applied over the dural closure, including the synthetic sealant and the dural substitute, or the combination of the two. And if the laminoplasty is performed rather than the laminectomy, then the absorbable or the titanium plate can be used to fix the lamina back into the place. And once the hemostasis has been achieved, then the incision can be closed in a multi-layer fashion, or closure intraoperative electrophysiological monitoring can be considered, and it has been found to reduce the perioperative surgical risk. So recently, in a small series, the minimal invasive tubular tethered or the release has been proposed as a safe and the viable alternative to the traditional open approach, with the statistically we can significant decrease in the blood loss and the length of the hospitalization in patients with the chronic intractable neuropathic mediated pain secondary to the recent tethered cord syndrome, or we can say the dorsal spinal cord stimulation, is a potentially effective treatment option. Here is definitely when you are seeing this kind of lesions, definitely in your mind coming, what could be the differential diagnosis? Actually, given the we can say the broad clinical presentation of the tethered cord syndrome, involving multiple systemic manifestations, include neurological, orthopedic, dermatological, and urological, and the differential diagnosis of the presenting sign symptom of the tethered cord syndrome is vast and beyond the scope of this review article. So the radiographically, the differential diagnosis for the underlying etiology contribute to the tethered cord syndrome and can be thought of similarly to the underlying etiology of the tethered cord syndrome, which include congenital and acquired etiology. And the differential diagnosis for the congenital, we can say the etiology of the tethered cord syndrome include dermal sinus tract, myelomeningocele, lipomyelomeningocele, fibrous or fibrous adipose filum terminale, or we can say diastomatomyelia. And the differential diagnosis of this acquired etiology of the tethered cord syndrome include the spinal cord tumor and the scar formation from the prior surgical intervention, infection, or the hemorrhage. So the long-term outcome following the spinal cord untethering, one study found that the weakness improved in 70%, stabilized in 28%, are deteriorated in 2%, and we can say the gait improved in 79% and stabilized in 19% and worsened in 3%. So the spasticity improved in 63% and the stabilized in the 39%. So the pain improved in nearly 100%. And lastly, happened. So the bladder function improved in 70% and they stabilized in 30% and deteriorated in 3%. And if bladder dysfunction is present, this continuous or we can say into the immediate post-operative period in the post children due to the temporary neuropraxia. This may last for the several days to the we can say even month, and the patient recover their ability to void within the first or 2 months post-operatively, and subsequently spinal cord untethering was required in about 30% of the patient who had previously undergone tethered spinal cord release. Of those patients requiring a second or we can say a second cord release, so the 39% required a 39% we can required a third, and 13% required a fourth tethered cord spinal cord release. So sometimes it means multiple steps or maybe an staging this, because you have to avoid the neurological injury. It happens sometime, but you can avoid if you try somehow. So the interesting phenomena following spinal cord untethering is a statistically significant gain in the height for the age percentile, and which may be the more significant in the we can say the children older than 5 years of the age. Any children with more than 5 years of age are giving that kind of good result in that regard. And the subsequent spinal cord untethering was required about 30% of patients who had previously undergone tethered spinal cord release. Of those patients requiring a we can say the second tethered cord release, and 39% required a third, and the 13% required a fourth tethered spinal cord release. So that's why I'm mentioning again, it is very important fact, we should know that. Actually, I want to show you here when a patient's MRI, the post-op MRI and the pre-op MRI, he was presented with the myelomeningocele, and then definitely he was treated post-operatively. He has a spinal diffractivism, and then definitely he has a myelomeningocele and the tethered cord syndrome. So I try to remove this with my team, and thankfully he has been untethered. And now I just want to present these pictures with you Yes, definitely there is a complication, and the complication following spinal cord untethering are uncommon, with the neurological or urological worsening occurring in around 3 to 5% of the patient, and the post-operative cerebrospinal fluid leak, or we can say the symptomatic pseudo meningomyelocele, occur infrequently, and if present should raise the suspicion for an occult CSF shunt malfunction. And the post-operative and the rehabilitation care must be needed. So the post-operatively patient commonly stay 1 or 2 nights in the hospital, and the brief period, I can say the brief period of the flat bed rest and typically overnighting during the initial post-operative day can be considered to reduce stress on the dural closure, and the ambulatory post-operative referral to the occupational or we can say the physical therapy may benefit bowel or the bladder dysfunction, and we can say the limb contracture. Regarding the, we can say the consultation evaluation of the neurological surgery is recommended to all patients with suspected tethered cord syndrome, and the patient may additionally benefit from an orthopedic surgery consultation. And if the limb abnormality or the scoliosis are present, so the urological consultation may also be required if urodynamic testing is pursued. So the evaluation of the neurological surgery, or we can say, is recommended for all patients with suspected tethered cord syndrome, and patient may additionally benefit from the orthopedic surgery consultation or neurosurgeon who they are doing the spine surgery for of the limb abnormalities, scoliosis, or are present. So the urological consultation may also required for the urodynamic testing is the means pursued. Tethered cord syndrome is well recognized cause of deterioration in the myelomeningocele population, with an estimated 1/3 of the patient required the spinal cord untethering in the childhood. And the tethered cord syndrome can have multiple systemic manifestations, include neurological, urological, dermatological, and the gastrointestinal or the orthopedic issues. So the long-term outcome following the tethered cord syndrome relief is favorable, with the improvement in pain, weakness, and gait spasticity or the bladder function observed. And in the minority of patients, recurrent spinal cord tethering may occur, requiring additional tethered and spinal cord release surgery. And we can say the surgical complications are uncommon but can occur, with the neurological or urological worsening occur in around 3 to 5% of the patient. Tethered cord syndrome may present with the collection of the systemic manifestation. Management of the tethered cord syndrome require a multidisciplinary and interprofessional approach, include the nursing, physical, occupational therapy, pediatric, primary care medicine, radiation technology, radiology, orthopedic surgery, neurosurgery, and we can say the urology. And only by working as an interprofessional team with open communication between the team members and the accurate, we can say, the record keeping, can proper recognition, evaluation, diagnosis, treatment, and the rehabilitation can occur. I want to present one case here as an analogy. It is a 8-month-old baby was referred by the pediatrician for concern of the sacral dimple, and we on history the mother doesn't report any neurological deficit that she has noted. On physical examination, in addition to the sacral dimple, a dark tuft of the hair, or the coarse hair, is noted, as well as the small hemangioma in the midline, and imaging consistent of the ultrasound at the 4 months of age. An MRI of the lumbar spine is ordered, and images are now available for definitely for review here. And I want to show here, but first of all, when I saw this patient, definitely in your mind something is coming, and which is the differential diagnosis. So the differential diagnosis came in my mind first, and I want to present here because it is definitely an educational video and as well as the informational video, but simultaneously the differential diagnosis, the neural tube defect, open if we consider, then the myelomeningocele, myelocele, closed if we can say the subcutaneous mass present, lipoma with the dorsal defect, lipomeningocele, lipomyelocele, or we can say the myelocystocele, or terminal, or the cervical. It could be anywhere, and if they are considered the closed. And if you are seeing the open, then open two are coming, the myelomeningocele and the myelocele. But when you are looking for the closed one, then you have the subcutaneous mass, maybe the lipoma with the dorsal defect, which we can say the lipomyelomeningocele, or we can say the lipomyelocele, or we can say, or it could be the other thing, the myelocystocele, terminal or cervical, or meningocele, and it could be there, or the cervical myelomeningocele, and the subcutaneous mass, for example, simple spinal dysraphism, or the spina bifida, persistence of the terminal vertical interspinal lipoma, or the intradural or filum terminale, or tight filum terminale, and the complex dysraphism, or the dorsal dermal sinus quadral regression syndrome, segmental spinal dysgenesis, split notochord syndrome, dorsal enteric fistula, and we can say the neuroenteric cyst, split cord malformation type 1 and type 2, So these all are when I want to explain you, and could be the differential diagnosis. So you can appreciate here, this is the L2 level, the L4 level, and L5, and you can see where the attachment is there, and it is the attachment of the spinal cord or the conus till L5, and definitely it is causing significant symptoms, as I mentioned you, and there's the skin dimpling also, as on presentation telling us about this problem. Definitely, as usual, we are doing the workup MRI, and we find on MRI image there is a fatty filum, and then further workup, definitely patient has been taken under the services of the neurosurgery, and the careful clinical assessment of the progressive neurological, orthopedic, or the urological issues, and considered baseline neurodynamic studies and symptoms and the sign of the occult spinal dysraphism has been done. So, as you know, there is a, and if there we can say the symptom and the signs and the frequency here. So we have to understand there is a, if we consider the foot deformity, it comes 39%. And if you think about the scoliosis is 14%. And if you are think leg weakness 48%. And if you think for the gait abnormality 16%. Sensory abnormality 32%, urinary incontinence 36%, recurrent urinary tract infection 20%, fecal incontinence 32%, and we can say the cutaneous abnormality also the 42%. So these, I just wanted to tell you that these foot deformity, scoliosis, gait abnormality, leg weakness, urinary incontinence, recurrent urinary tract infection, fecal incontinence, or we can say the cutaneous abnormalities. These are the findings here, and we have to understand, and one of these findings or two of these findings or three of these findings you can find in your patient.